Hello everybody, welcome to Chronic Pain Summit Series presented by Johns Hopkins University School of Medicine. My name is Dr. Glenn Treisman, and you are tuned into a live broadcast of new insights into the pathophysiology and assessment of chronic pain with Dr. Michael Clark. Dr. Clark and I are pleased to serve as chairs of the first Pain Care Live Chronic Pain Summit Series. Today we'll be talking about new insights into pathophysiology and assessment and opioid analgesics in the management of chronic pain. Today's sessions are live interactive broadcasts, which allow us to take questions in real time throughout this presentation. You can send your questions to us anytime during the program through the box in the lower left-hand side of your screen. Dr. Clark is an associate professor and vice chair of the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. Before we get started, I would like to remind our audience that we'll be taking questions in real time throughout this presentation. You can send me your questions anytime during the program. There's a little box in the lower left-hand side of your screen. Feel free to use it. Dr. Clark, welcome. Good to see you.
Nice to see you. Thank you for having me.
Oh, it's my pleasure.
Well, let's jump right in. Today we wanted to talk about new insights into the pathophysiology and assessment of chronic pain. Our objectives today are to understand the different components of the nervous system that process nociceptive information and exhibit some of the pathophysiologic mechanisms involved in this system, which fall under the larger umbrella of neuroplasticity. Also, to compare some of the pharmacologic mechanisms of medications that are commonly used to treat chronic pain, and to utilize more practical strategies to improve their effectiveness. Let's start with the pathophysiology of pain and understand some of these components and how they interact. This really is not just a simple wiring diagram, but really a very dynamic system with multiple components. As you can see here, all of us have the ability to sense noxious stimuli and respond to them accordingly. This is part of our alarm system, and it helps to keep us safe and avoid more serious traumas. In the red portion of this slide, you see the pathway highlighted for the ascending side of this circuit. Information comes in from the periphery, rises up through...
Hold on a second, Dr. Clark. I'm getting messages that they're not hearing audio over our system. Many messages. Can you check the audio? Sorry.
It's okay.
Go right ahead.
So, if we look at this slide, we're highlighting both the ascending and descending pathways of nociception. In red are the ascending pathways that bring in information from the periphery, synapse in the spinal cord, rise up through the spinothalamic tracts to the brainstem, and then on up into the cortex where pain is perceived. In blue on the right-hand side of the slide are the descending modulatory pathways of this system and have the ability to both facilitate or inhibit nociceptive transmission. If you think about the different types of pain, we do not yet have the specificity we'd like to be able to tailor our management to individual conditions. But we do have a fair bit of information that helps us make a distinction between the normal system, highlighted in line A on this slide, against the other major categories of dysfunction in pain. On line B are inflammatory conditions where the components of the system are essentially normal, but the problem really lies at the level of the stimulation of the system. The inflammation and tissue injury turn the system on chronically, and the patient is experiencing pain over a long period of time. That stands in contrast to neuropathic pain syndromes on line C, where there is some damage or dysfunction to a component of the neurologic system, the peripheral nerve, the spinal cord, or even higher. And finally, at the bottom is what might be a bit of a wastebasket category, but yet is emerging into a third distinct type of pain. These are disorders where patients seem to be exquisitely sensitive to all sensory phenomena, side effects of medicine, the distress of trying to perform in various circumstances. So the patient with fibromyalgia, irritable bowel syndrome, certain types of low back pain and headache syndromes, we can't find the inflammation that's stimulating the system. We can't find the broken or dysfunctional part in the peripheral nerve or the spinal cord, or even at the level of the brainstem. And now, as functional imaging emerges, we begin to see that there's evidence at the level of the brain that these are patients who have a primary form of central sensitization as the cause of their difficulty. If we look at the basic system and its dynamics, we see in blue that there is a dose-response curve, so that for any given noxious stimulus, there is a threshold for detecting it, and at that point, it really is experienced as not particularly unpleasant. As the intensity rises, at some point, the person will begin to describe the characteristics of that stimulus, whether it's temperature or mechanical pressure. As the intensity increases, now we see that it becomes painful, and the person will describe it as a noxious stimulus. And at the top of the curve, we reach the plateau where the person can no longer tolerate this stimulus and wants it to stop. When the system is damaged or injured in some way, essentially the curve shifts to the left. And as a result, there's a form of sensitization that occurs, because now the mild innocuous stimulus is actually experienced as painful, and that's the phenomenon of allodynia. And the mildly or moderately noxious stimulus is experienced as severely noxious, and that's the phenomenon of hyperalgesia. There are many mechanisms by which this curve can shift, and usually several are at play. Now, again, if we start with the normal system and talk about the different components, the system has the ability to transduce the physical characteristics of a stimulus like hot or cold, sharp or dull, the presence of hydrogen ions or changes in pH, into an electrochemical stimulus, which is conducted up the axon of the peripheral nerve to the level of the spinal cord, where there's an immediate withdrawal reflex that kicks in so that we move that extremity so that further damage isn't sustained. But then the bulk of the information is transmitted up to the brain, where the perceptual experience of pain is put together. And as a result, there's not only the physical intensity and characteristics of the stimulus, but also thoughts about how to avoid that stimulus, how to plan for the future, how to learn the context in which it's occurring, and then there's the unpleasantness or emotional reaction attached to pain. If we look at the peripheral nerve, you'll remember that this is not just a single fiber, but in fact a bundle of many different types of fibers, much like a transatlantic telephone cable. The large, fast-conducting, thickly myelinated A beta fibers are not carrying nociceptive information. They're what allow us to move and interact with our environment and engage in fine motor skills. But the smaller, thinly myelinated A delta fibers are carrying nociceptive information and are generally thought to be associated with the more electrical, shooting, evoked pains of a chronic pain state, in contrast to the thin, slow-conducting, unmyelinated C fibers, which are generally attributed to the more constant burning background pain that patients will complain about and tend to be more responsive to changes in pH and high temperatures. If we look at that peripheral nerve, its sensory afferent end, the membrane is filled with specialized receptors and ion channels, all involved in the detection of threat and the conduction of that information upstream. And so in the presence of tissue damage, you'll recall that mast cells, macrophages, neutrophils enter into this space and release a whole soup of neuromediators and inflammatory products. The arachidonic acid cascade starts to produce prostaglandins, bradykinin is released. All of these products will interact with the cell membrane in a very specialized way. And as a result, this membrane gets turned on and sends an action potential generated by voltage-gated sodium channels. But what happens over time is that if this stimulus is intense, if it lasts for a long period, if there is further damage and destruction of tissues so that the inflammation burden increases, what we see is